So, okay, after we saw that this exudative preponderantly serous inflammations look on the surface of the skin as evolving lesion from macula to papula to vesicle or bulla formation, which are breaking, remaining after that covered by a crusta beneath, healing the lesions produced by a lot of different etiological factors. Now we'll see how these serous inflammations look in another location, meaning in the preform cavities, meaning pleural, pericardial, peritoneal, or even subarachnoidean cavities. Here, in this location, the inflammation consists in accumulation of a serochitrine liquid, meaning clear, slightly yellow liquid, which has high density, being very rich in protein, low molecular protein but rich in protein, which it's making the difference between the same looking liquid in the same location in transsudates, meaning in non-inflammatory edemas, in which the liquid looks in the same way but have a low density, being low in protein content. This in this location, the liquid, it's possible, the presence of liquid, it's possible eventually to be associated with edema of the affected serosa, which this time will be an inflammatory edema of it. And in fact, it is, after all, this liquid of inflammatory edema. This is why it's so rich in protein. The other type of edemas with other mechanism of production, like in cardiac insufficiency or in hypoproteinemia, the other mechanism, the formed liquid will be with low content in protein. And here it's an image taken not more than yesterday, when I had an autopsy to a small 8-month child who died for not yet very clear reasons, having probably a meningoencephalitis, viral most likely, on the background of otherwise metabolic disorders. At least for the moment macroscopically looks like that, but who also had in the pericardial cavity an amount of about 20 milliliter of serochitrine liquid. And this is how it looks, the serosa itself. This child, it's much too young to have adiposity deposed here. So it's not adiposity, so it's not yellow, in fact, we can see, but still having this whitish exuberated serosa because of edema of it. So this is how it looks, the edema of serosa. It's a quite rare image to have. I saw it in my life twice or 3 times, not more, at least in children. In the thickness of the compact organs, again, the serous inflammation take the form of an inflammatory edema, meaning from the signs of Celsius, it was the tumor. From the list of Celsius signs of inflammation, meaning the affected area becomes harder on palpation and eventually even reliefed on the surface, if it has a surface, like here in the case of skin, also being the rest of the Celsius sign present, rubor, dolor, calor, and so, but tumor, it's the sign generated by the local inflammatory edema, which is possible to be superficial enough, like in the case of skin, to be seen, or possible to be in the more deeper organ in the same way. In most situations, being a favorable evolution, being quite not so severe inflammation by itself, as we saw by liquid accumulation in the serosal cavity, it's eventually possible to threaten the life. Now we'll see a little bit more severe, more advanced exudative inflammation in which the capillaries are dilated a little bit more to permit the exudation from the blood, not only of the liquid with salts, but also of proteins with large dimension, like fibrinogen. This fibrinogen is a soluble protein in the blood, but once exudated in the outside blood circulation and entering in contact with air, even with small amount of it, it's coagulating instantly, becoming a solid protein called fibrin. A lot of etiologies are possible, bacterial, viral, or even chemical substances, or even mechanic factors can induce the same result. So again, just looking for such a fibrinous inflammation, we can describe it as being fibrinous inflammation macro and microscopically, but it's not in our competence to put an etiological diagnosis here. This fibrin, once deposed, being solid, as I said, macroscopically, looks like a white-gray filamentous butter-like substance. And microscopically, being a protein, it's obviously a red amorphous substance. So hyaline looking like substance. On surface of mucosas especially, this fibrinous inflammation take the aspect of pseudomembrane formation. This pseudomembrane being in fact coagulated fibrin and being deposited and covering the surface of the affected mucosa. For the upper respiratory tract, when is affected, take the name of diphtheric croup, this pseudomembrane, despite the fact that it's not only diphtheria which can produce it, but also other etiologies. Like, for example, viral infections can also generate the same, or even mechanic trauma of the upper respiratory tract. We are seeing, for example, this fibrinous deposition in the upper respiratory tract quite frequently after intubation, orotracheal intubation, when they remove the tube from the respiratory tract. It's as a remain, we can see deposition of fibrin here because of mechanic compression and irritation of the mucosa with the device. This deposition in the upper respiratory tract of solid fibrin with formation of a membrane, fibrinous membrane, is particularly dangerous for small children who have the upper respiratory tract very narrow. And this pseudomembrane formation here can obstruct this upper respiratory tract and to generate suffocation and eventually to be even lethal. For this reason, diphtheria, a quite common disease in the past, was extremely dangerous for small children who were in the past dying frequently because of it. And this is why a vaccination program was necessary to be introduced for this particular disease very early. They are all children in the world, at least in theory, vaccinated for this disease starting with the age of 3 months. Until then, in the blood of this newborn, they have antibodies against diphtheria coming from mother. Mother also having these antibodies because she was also vaccinated when she was a small child. Because otherwise this vaccination is extremely efficient. Yes, it's true it's needed more than 1 dose of vaccine, but until the age of 1, it's finished all these doses and you will remain with a very good, efficient immunity against this disease for the entire life. So it's a very good and efficient vaccine. Despite this, the disease is still present in the world in very rare, isolated cases because the vast majority of population is vaccinated, but still possible to have extremely rare such events. It was described not more than 1 year ago, such a case in a child in Greece, for example. It's exactly 1 year ago. The same aspect of pseudomembrane is formed also in the digestive tract, but by dysentery or other bacteria generating a particular type of enterocolitis. They are called pseudomembranous enterocolitis, obviously evolving with diarrhea and fever being bacterial infections of the digestive tract. But for this localization, it's not so dangerous because they are not able to occlude the digestive tract as it was for the upper respiratory tract in the first situation. So they being treated obviously with antibiotic and everything else for such a infectious diarrhea, they will be spontaneously removed, being detached from the surface of the intestinal mucosa and liberated outside with no consequence and with healing after no consequence at all. Here, quite rare images of this diphtheric group. We already discussed that this diphtheric bacteria is producing also exotoxins acting at distance and generating that particular type of alterative myocarditis with tiger striped myocardium macroscopically. And this is what the bacteria is doing at the site of infection, where the bacteria remain. It's not invading more, but it's enough to kill by generating this local deposition of fibrinous pseudomembranes. Here it's another such an image in the lower part of the respiratory tract. But all these are so rare nowadays that we're in the situation to see the disease and not recognize it because we forget of its existence. This is why in Dr. House season 8, episode 8, Dr. House was put in the situation to make such a diagnosis in a patient. He was specialized in rare diseases which make the diagnosis very difficult for other doctors. He being, if you saw the movie, it's extremely educative one. It's needed for any student in medicine to see all the seasons. It's extremely educative. But he, in this particular episode, put this diagnosis after making a tracheostoma because the patient, despite the fact that it was an adult, was suffocating, and looking in the optic fiber in the tracheostoma, he saw the pseudomembranne and he put the diagnosis. Obviously, this image is an electronic generated one, it's not a real one, but otherwise extremely suggestive for what should like such a fibrin pseudomembrane on the surface of respiratory tract with occlusion potential, very high occlusion, especially for children. And this is how it looks for the digestive tract, the pseudomembrane. They are not white anymore because obviously in the presence of feces, they are also colored by this feces. But otherwise they are red protein deposed on the surface of beneath ulcerated mucosa. This is a smaller magnification to see the normal mucosa here, the ulceration area, so no mucosa anymore in this area, and the covering with this homogeneous red protein here on the surface. Here again, much smaller the ulceration here, but still the presence of the membrane, which is at the site of ulceration adherent to the submucosa. But in time, it's the mucosa it's healing, recovering the ulcerated area, and the mucosa, the pseudomembrane, it's detached by the healing process. On serous surfaces, again, in the preformed cavities, fibrin, it's again a solid substance deposed like a white butter-like substance on the surface of the pericardium or of the pleura or of the peritoneum and so. For the fibrinous pericarditis, how it's called, this deposition, the etiology is possible to be quite diverse. Uremia, meaning we'll see and we'll discuss about it in the next slides. Uremia being one of them, myocardial infarction being one of them, but even much more frequent than any other etiology, it's the mechanic trauma of the pericardial serosa in open heart surgeries. Each time when it's needed to operate the heart, the pericardial layer obviously it's open by surgeon. They are working what they are working there, but inevitably they are generating mechanical trauma for the serosa itself. And when they finish what they do there, they never close back the pericardial cavity. It remains open forever because they already know that the fibrin, which even if it's not yet seen macroscopically, will cover the surface, generating adherences between the visceral and parietal layers of the pericardia, of the pericardium, and closing in this way the cavity. These adherences can be narrow. They are called bridges, or be on large areas called symphysis. But in both situations, it's fibrin, which if it's in very small quantities, possible to be resorbed. But if it's in a larger quantity and after such a surgery, it is always in large quantity, it's not resorbable anymore. And for this reason, we assist to replacement of the fibrin, like in the case of thrombus, which also was made by fibrin, with a granulation tissue, and at the end, after a few weeks of evolution, transforming the fibrin deposition in connective tissue. and making these bridges and civices as permanent connective tissue adherences between the layer of the serosa. And it's the case for all cavities, not only for the pericardium. The same thing happening in the peritoneal cavity after abdominal surgery. The same thing in the pleural cavity eventually. These adherences formed here has no big deal importance for the function of the heart or the lung. Becoming adherent, the serosas layer don't impair the function of the beneath organ. The heart is continuing to contract, the lung is continuing to be respirated without any problem, and even eventually it's possible in some situation to be beneficial, these adherences, because by large symphysis, the cavity it's in fact not present anymore. It's not possible for this cavity to be filled with liquids. So for future of the cavity, here it will be not possible to accumulate transudate in hydrothorax, hydropericardium, or exudates in serous inflammations of the serosa, as we saw before. These liquids being by themselves more dangerous because they compress the lung and the heart. Not being able to accumulate anymore, it's a good thing after all. Pneumothorax also a result of breakage of the lung. It's again impossible to appear in this context. So even can have good consequences, these adherences formed here. For the pleura, again, not only mechanical, but also inflammations of the lung beneath the serosa, meaning in lobar pneumonia or tuberculosis, is possible to generate the same thing with the same evolution to reabsorption if it's small quantity, or bridges and civices if it's quantity. And here we have such a heart with this yellow, whitish, creamy substance deposition on the surface. From a semiologic point of view, this deposition here make the surface of the epicardium being not smooth anymore and generating friction, which is painful, which is possible to be palpated and also being auscultation with the stethoscope. And it's called like that, friction sounds. And this is how it's put, the diagnosis of such a fibrinous pericarditis or fibrinous pleuritis, because it's the same thing there too. So by stethoscopic auscultation. But in this case, despite the fact that the deposition is not compressing, it's not affecting the heart itself, the patient died. Not because of the presence of fibrin here, but because of the myocardial infarction which was beneath. It is called fibrinous epistenocardic pericarditis, it's called, in fact, and it's considered to be a complication of the myocardial infarction. We'll see this in second semester when we'll study again the myocardial infarction with complications. And because beneath the muscle died, from this dead muscle, inflammatory cytokines are relieved because it's a necrosis, and necrosis is triggering an inflammation, as we already discussed. And this inflammatory substance are diffusing to the surface, to the serosa, and it's triggering here this otherwise aseptic, not microbial, not viral inflammation of the serosa. And as I said, any mechanical trauma in open heart surgery, it's doing the same thing. We have another such an image with this butter, whitish substance, initially like a butter in consistency, and in time being transformed by intermediate of granulation tissue in fibrous connective tissue, generating bridges or adherence, and looking like a eosinophilic amorphous substance because it's a protein deposed on the surface of the uh, pleura or of the pericardium. Here is the pericardium, here being the muscle of the heart, the adipose tissue beneath the pericardium and the muscle. This was called lipomatosis cordis, and it was specific to appear in obesity. So we can judge this image as being the heart of an obese person. And on the surface was this deposition of fibrin, which from the layer, serosa layer to surface, start to be invaded by polymorphonuclear cells, which will generate tunnels, small ones, which will become new form capillaries, transforming the fibrin in granulation tissue and in evolution in a connective tissue scar. So this is how it's evolving. Here, such bridges, so small in surface the adherences, but when they are larger, it's called symphysis, and in fact, the entire cavity is disappearing. It's happening, as I said, in the same way in other serosal cavities. And this is a reason why, for example, if you are a surgeon and you operate in the abdominal cavity something, you will generate such adherences to be formed after your performance. And if it's needed to enter again in the abdominal cavity, these adherences will not be pleasant at all, their presence, because you need to remove them. And it's taking time and patience. And this is why other surgeons usually refuse to operate after you. So if you operated initially, you will operate again if it's necessary, obviously, because you will remove your mass, what you generate in the abdominal cavity. So it's your job to do it again, not other jobs to clean your mess. Here in this image, we have another image of fibrinous pericarditis. It's true that it's mixed with blood, so this means that it's a fibrinohemorrhagic pericarditis. It's more severe. And it's described here that appeared in a uremic patient. What this means? Means that the patient have renal insufficiency, and it's not treated with hemodialysis. So quite rare to see such a thing in our days because we have enough hemodialysis capacity to treat all the renal insufficiencies in our country at least. But it was not the case in the past to have this facility. So in the past, I had the occasion to see such cases dying because hemodialysis was not available for them. They are dying very slowly by gradual elevation of urea in their blood. Uremia, calling this accumulation, is higher and higher, and the patient is trying to remove this urea. If it's not possible by urine because the kidney is not functional anymore, then it's trying by sudoripary glands to eliminate it outside. So in this try, the patients are smelling like urine continuously. It's not a pleasant smell at all, but this is what their body can, at least to try, but insufficiently is doing it because the uremia is still higher and higher and higher, despite the fact that obviously they are put in a diet with minimal urea generation, but despite this they evolve slowly but surely, and after a certain level of urea in the blood, this urea became chemically irritant for the pericardium and is generating the appearance of such a pericarditis. Not by itself dangerous, but with pain and possible to be diagnosed by auscultation as a pericardial friction sound. But in the old classic semiology, this clinical sign appearing in the evolution of an uremic patient was considered to appear just 24 or 48 hours before they are dying. But they are dying not because of the pericarditis itself, but because of intoxication of the brain. The urea became so highly, the concentration of urea in the blood so high that even it's possible to penetrate in the hematoencephalic barrier and to enter in the brain and to kill in this way by intoxicating the brain. The classic semiology described this pericardial friction sounds that you can hear with your stethoscope coming just hours before the dying of the patient as being the bell sounds of the uremic patient, meaning by ringing their bells means that it's announced in this way the sudden, very short coming death of the patient. So it's announcing the death, but it's not dying because of the inflammation of the pericardium itself. Here the same deposition of this whitish butter-like substance on the surface of the pleura this time in one of my cases, generated by, I don't know exactly what, beneath inflammation, possible pneumonia or bronchitis, with adherences again forming here, with symphysis bridges in the peritoneal cavity, as I said, each time when it's surgically open the peritoneal cavity for any reason, for operation, such deposits of fibrin will remain in the peritoneal cavity. Obviously, if the surgical intervention is a minor one, the trauma is localized and minor for the serosa, and the deposition will be with small quantity of fibrin, with very high like possibility of resorption. But if it's a large operation or the surgeon is not so skilled and he is traumatizing the serosa intensely, the quantity of fibrin will be quite intense and the resorption will be not possible anymore. Such bridges or symphysis, which for this time for the abdominal cavity can eventually interfere with the normal transit of the intestinal tract, meaning they can strangulate the bowel and in this way generating an acute obstruction of it. It's called mechanic ileus, this obstruction, and it is an emergency by itself, needing to be operated, opening the cavity and sectioning. It's quite easy, just sectioning the bridge and everything will be resolved. So not big deal, but it's an emergency and should be done as early as possible. And happened, at least in the past, quite frequently, to have an initial operation for any reason in the abdominal cavity, developing adherences with bridges, with occlusion, intestinal occlusion, needed another operation to resolve the occlusion. And after this second operation, other bridges were formed, other occlusions were appeared with relapsing. And again and again and again was necessary to reopen the abdominal cavity in such cases. To avoid such a thing or to minimize this type of fibrinous inflammation of the serosa after mechanical trauma of it, we are nowadays now trying by laparoscopic tools to operate the abdominal cavity each time when it's possible. Because by laparoscopic approach, the trauma is minimal and least risk for appearance of such complications. After healing the fibrin in connective tissue scar, it's possible for this scar to be seen as a white plaque on the surface of a serosa, of the liver, of the spleen, of the lung, of the heart. These hyaline plaques are in fact the scars remaining after the healing by connective tissue formation of the fibrin initially deposition. They don't have any signification by themselves, but they are looking sometimes quite strange. You should know what they are and not doing anything if you are seeing these white plaques on the surface. It's another possibility for a scar, and we already discussed about this. The scars have the capacity by dystrophic calcinosis to depose calcium inside. If it's in small quantity, just focal deposition of calcium in this scar, here is such a scar on the surface of the pericardium, being the muscle beneath, and with calcium deposition inside. When it's just focal deposition, it don't have any significance at all. The general function of the heart, it's not affected, and everything it's asymptomatic by itself. But are in some rare situation possible for the pericardium entirely transformed in a large symphysis to be calcified entirely and to close the heart in a rock inside a rocky surface, which will this time interfere with the capacity of obviously the heart being adherent to a rock, which is rigid, will not be able anymore to contract or to dilate. A very severe otherwise condition generating a very severe cardiac insufficiency and being lethal if it's not rapidly surgically remove this stone encircling the heart. It's not a big deal, but you need to do it rapidly. It is one of my pleasures in medicine, at least, the name of this condition in German. I don't know German, and it will be impossible for me to learn it ever. But I like the name Germans give to this particular constrictive pericarditis name, otherwise in English. They are calling it Panzerherz. Panzer obviously coming from the tanks used in the Second War. Suggestive name given. Okay, inside the compact organs, this fibrinous inflammation, it's impossible because, as I said, it's needed to have a contact even with a very small amount of air to coagulate the fibrinogen in fibrin. So inside a compact organ, such a thing is impossible. So we will not have fibrinous inflammation in compact organs, with only one obvious exception, which is the lung, which has inside the parenchymatous organ a lot of air. And this inflammation, fibrinous inflammation of the alveolar spaces, it's called lobar pneumonia. Being bacterial in etiology, pneumococcus being the most frequent but not the unique bacteria generating it, and who is evolving this inflammation in 4 stages or phases. The first, called congestion, it's followed by second and third phases called hepatization. First, the second being red hepatization, the other one being gray hepatization. And at the end of this evolution, the last phase being the resorption of the fibrin. The hepatization phases mean inside the alveolar spaces is present fibrin, no more air in the alveolar space, just fibrin, and giving to the otherwise spongy organ liver-like consistency on palpation. This is why it's called hepatization, because have the consistency and even the color mimicking liver. We'll discuss more about these phases of evolution of lobar pneumonia in second semester when we'll discuss about inflammations of the lung more largely. But for the moment, it's a 4-phase evolution. Natural evolution only because normally if we have a lobar pneumonia in the first stage of congestion, which is initial phase, we already have fever, we already have cough, we already have crackment sounds and auscultation, so we already have all the clinical signs for a pneumonia and will not wait in our days now for a normal natural evolution, but will give antibiotics as early as possible, healing in most situations very rapidly these pneumonias and not letting them to evolve naturally. But when the treatment is not given for different reasons, these hepatization phases are appearing. Fortunately, they are only for a period of time present there. This fibrin, solid protein occupying entirely a lobe, the all alveolar spaces in the lobe, so the lobe will be not anymore respirated. For the moment, it's quite an unpleasant period. But in the evolution, like any fibrin, in small quantity, because it's each fibrin is in one alveolar space in a very small quantity. So being in small quantity is resorbed. This is why the fourth and the last phase is called the resorption phase. And by resorption, it's regained the normal structure of the lung with the normal function. So it's healing in most situations. But extremely rare, it's possible for this fibrin not to be resorbed from the alveolar spaces because of insufficient function of the polymorphonuclear cells, which are the cells called at the site to resorb by phagocytation the fibrin. And because they are insufficient in number or insufficient in function, because of a genetic dysfunction, in fact, it's possible for this fibrin to remain, not to be resorbed. And by remaining, they will evolve in the same way by granulation tissue in a connective tissue, which will destroy forever the affected lobe, so which will be forever transformed in a connective tissue scar and not healing anymore. Fortunately, it's a complication of the evolution of bacteria. It's a quite rare one. And here is how it looks, such a lobe, like a liver macroscopically having, and inconsistency too, having all the alveolar spaces full with these very, very tiny filaments of fibrin occupying entirely all the alveolar spaces of a lobe, not all the lobes, just one lobe. This is why it's called lobar pneumonia. And now we are going further in another type of exudative inflammation in which the capillaries are dilated so much that in the gaps between them can exudate outside even polymorphonuclear cells. They are larger than red cells, but they are able to produce pseudopodic prolongations, and by this to enter in much smaller spaces. The red blood cells cannot do such a thing, so for them to exudate outside, it's needed even more severe dilatations of the capillaries. This exudation of the polymorphonuclear cells in very large quantity, it's necessary for these polymorphonuclear cells to exudate outside to reach the site of microbial inflammation, because it's microbes who are triggering this purulent inflammation, and polymorphonuclear cells are attracted at the site to phagocytate, at least to try to phagocytate these microbes. The result will be a mixture of microbes with polymorphonuclear cells, some of them still alive, some of them killed by the toxins generated by the microbes, and all in large quantity. And also, these microbes are killing not only the polymorphonuclear cells, but also are killing and dissolving with enzymes the local cells of the affected tissue. By this liquefaction, the microbes are generating the proteins needed for them for nourish and flourish. Also, a certain amount of edema fluid is added to the content, and the result will be a liquid mixture, which is called the pus, which is not transparent anymore, and is yellowish creamy macroscopically. In the staphylococcal etiologies, it's whitish and hemorrhagic a little bit in streptococcus etiology, grayish and smelling badly like a deteriorated cabbage in E. coli etiology, bluish in pyochanic etiology, but despite all the described differences between the pus aspect, it's not our job at all to put such etiologic diagnosis. We are only describing that it's a purulent inflammation macroscopically and microscopically, but it's not our job to put the etiology diagnosis. Is the microbiologic examination of the pus necessary for to having such a diagnosis. And here how it's looking, a little bit whitish, yellowish, creamy, this pus. As I already said, in the pus we have this mixture of microbes grown in sometimes as isolated microbes or in colonies. When they are in colonies, are possible to be seen as a basophil granular substance in hematoxylineosine. The dead cells or cellular detritus are local necrotic cells, but also polymorphonuclear cells which was killed by the toxins produced by microbes, and a lot of polymorphonuclear cells still alive. some being normal in aspect, some having the bacteria inside their cytoplasma, so they already phagocytate bacteria, and some other being necrotic, dead, or in the way to die. So necrobiotic cells. And this is how it looks. In fact, it was a tissue here, which we don't see anything anymore from the structure of the tissue. Not important which type of tissue, lung tissue, liver tissue, kidney tissue, but the tissue itself is not seen anymore because it's destroyed and replaced with what we see. It's a lot of polymorphonuclear cells, and from time to time some basophilic granular substance accumulation, which are the colonies of microbes. This is the general look of pus microscopy. Here on higher magnification to see these polymorphonuclear cells accumulating in an area in which the former structure of the tissue is not anymore seen. So it's replaced by this accumulation. Etiology is mostly bacterial, as I said, but possible with others etiology, chemical, including from which this terebinthine oil, which is otherwise substance used in constructions, for paintings, surfaces, as a diluent substance for paintings. This terebinthine oil is used in experimental purulent inflammation. So they inject anywhere they want to study, and by this presence, purulent inflammation is formed. So it's used for this purpose in experimental studies on animals. On the surface of the skin, the purulent inflammation can be localized on hair follicle or on pseudoripary glands or inside sebaceous glands, generating each time a smaller or larger collection of vesicles full with pus, and having different names according with the anexa of the skin involved in the infection. Pustula, folliculitis, furuncles, carbuncles, hydradenitis, suppurative hydradenitis are all such names. And looking in this way as a smaller or larger collection of pus in relation or not in relation with the hair follicle, and microscopically being small cavities full with pus in the epiderma or beneath it. Here it's intraepidermal pustula. It's a small cavity which was possible eventually to be before with a serous liquid inside, and by overinfection with microbe it's transformed in purulent inflammation. In the preformed cavities, we have, like in the serous inflammation, the accumulation, but this time of the pus itself, which is not anymore transparent. It's have the name of empyema for the pleural cavity. It's a particular name for the purulent pleuresia or pleuritis, but it's equivalent, so you can use any of this terminology: purulent pleuritis, purulent pleuresia, or empyema is the same thing. Purulent pericarditis, peritonitis, meningitis, arthritis, all other cavities are named in this way, consisting in the accumulation of more or less liquid, more fluid liquid, yellowish creamish, hemorrhagic or not, according with the etiology, but not transparent anymore. Here obviously in the pericardial cavity, here obviously in the pleural cavity, and here obviously in the peritoneal cavity. All of them are extremely severe, need to be drained, and obviously being microbial, treated with microbes, with antibiotics. For the pleural and pericardial cavity, antibiotic treatment, it's enough. It's not necessarily, or eventually to drain if it's in large quantity the pus, but otherwise it's not needed to do anything else. But for the peritoneal cavity, purulent pericarditis, it's almost, not always, but almost always the result of perforation of a segment of the digestive tract. Gastric ulcer perforated, perforated appendicitis, perforated cholecystitis, enteritis, and so, but each time it's a perforation. And for this reason, it's always necessary to open the cavity, to find the perforation, to resolve this perforation, and after that, cleaning the cavity, instilling in the cavity an antibiotic, a dissolved antibiotic, and after closing the abdominal cavity, giving a lot of antibiotic, because it's a very, very dangerous condition with very high lethality, this purulent peritonitis. And here a purulent meningitis, again, meningococcus being the main etiology, but possible to be generated by other microbes too. In the thickness of the compact organs, the purulent inflammation is starting initially as a diffuse infiltration between the cells of the affected tissue with polymorphonuclear cells. So initially the microbes are there. They are already attracting polymorphonuclear cells from the dilated local capillaries. They are exudating outside beneath the local cells, but the local cells are not yet destroyed. In this situation, it's an initial moment of the evolution of a purulent inflammation. It's called a phlegmon formation. But if antibiotic treatment is not given very rapidly, this microbe will kill the local cells, and initially phlegmonous diffuse inflammation will be transformed in an abscess, meaning in the appearance of a cavity by necrosis of the local cells, filled with pus. We have such examples of phlegmonous inflammation, mostly in the wall, the thin wall of segments of digestive tract, particularly the appendix. It's generating such a type of phlegmonous inflammation. Here we have such an image with pus presence in the lumina, and also infiltration by ulceration of the mucosa of the pus in the thickness of the wall. It's necessarily a high magnification to see that the muscular cells of the wall are still there, but between them a lot of polymorphonuclear cells, which means a phlegmonous appendicitis, which in evolution, if it's not removed surgically, the appendix, or at least an antibiotic to be given, in evolution, obviously, they will kill the muscular cells, transforming this in an abscess, but being so thin, the thickness of the wall of the appendix, this abscess formation will in fact generate perforation of it. So the abscess formation, it's equivalent with the abscedated or perforated gangrenous appendicitis. In the thickness of organs, the abscess, it's coming in evolution after an initial phlegmonous short period, and it's possible to have such abscesses anywhere, in any compact organ, from brain to lung to myocardium to kidney to liver, anywhere. Smaller or larger, such abscesses. Once they are formed, obviously the patient has fever, has high quantity of polymorphonuclear cells, called also in the blood, because of called leukocytosis, because they are producing bigger and bigger quantity to came at the site of infection in higher and higher number to phagocytate the microbes. The organism is not counting in our antibiotic treatment. So the polymorphonuclear are coming in higher and higher number, trying desperately to kill all the bacteria. But the bacteria, it's flourishing. And in most situations, the polymorphonuclear cells will not be able to clean the microbes from the area. And in such situation, the organism has only one solution to resolve the problem and to stop the progression of the infection. And this only solution is to put a wall between the pus with the microbe inside and the rest of the organ. And this wall, it's the wall of an abscess, which is initially formed by a granulation tissue. And for this reason, it's red in color, being rich in newly formed capillaries surrounding the cavity of the abscess. And it's called in this phase acute or recent fresh abscess. In this period of time, which is quite short, a week or something like that, the patient continue to have all the symptoms associated with the infection, meaning fever, leukocytosis. But in a week or so, this granulation tissue will evolve in a connective tissue scar, which is impermeable for the microbe itself, so it's a barrier, very efficient one, and will encircle the abscess completely. In this moment, despite the fact that microbes, the pus is still there inside, the symptoms will disappear. Fever will disappear, leukocytosis will disappear. In this way, the organism making the isolation of the body from the aggression. It's a quite efficient way of evolution by this transformation of an acute, recent, or fresh abscess in a chronic one. So the old chronic one have a connective tissue wall, which contains inside the cavity the pus, having all the already described aspect of the pus. What is important to know about this evolution of the abscess from acute to chronic is the fact that once became chronic, okay, all the symptoms disappear and you can live with such a abscess in your body, anywhere in your body for a very long period of time, even knowing that you have such a thing. And I saw such cases dying for different reasons and having in their body abscesses as big as my fist, for example. But with no consequence at all. Unfortunately, any abscess in any location once formed and became chronic, isolated and asymptomatic, have a permanent tendency for the microbes inside, for the pus inside, to find a weak point of the wall and to break it and to invade again the rest of the body. So it's a perpetual tendency to find such a way of fistulization, it's called, a way for eliminating from inside the cavity the pus in outside, for the microbes, obviously, with the goal to infect more and more from the body. This fistulization process, it's a very dangerous one because it's possible in the process of fistulization for such a fistula to open inside a vessel, blood vessel, assisting in such a moment to a perfusion, if you want, with the pus inside the blood, transforming suddenly otherwise localized asymptomatic purulent chronic abscess in a septicemia, even more severe in a septicopemia, meaning the microbes, the pus is not only the microbes because it's the pus with the rest of the contents of the pus being floating in the blood as septic, it was called embolia. They will circulate at distance and will generate at distance new and new abscesses, which are extremely dangerous and even possible lethal. For this reason, once discover the presence of an abscess anywhere in the body, it's indicated to be eliminated surgically and not to let them stay there, despite the fact that it's asymptomatic for the moment. The risk is too high, it's too big for them to fistulate. So it's not enough to enter with a needle in the cavity and to absorb the pus from inside. It's not enough because microbes are still remaining in the cavity, adherent to the wall of the abscess, and the abscess will be reformed after such a way of treatment. So it's always needed for the surgeon not only to drain an abscess. It's enough for the, for example, in an acute recent abscess to be drained, but not for the old ones. They need to be removed with the capsule itself entirely. So this is the indicated way to treat. Obviously, if it's possible, because, for example, in the brain, if you have an abscess in a particular area, which is extremely dangerous to be reached by surgery, you prefer not to do anything. Just let it there, and if it's bad luck, which will kill the patient, okay, but at least it's not you who is killing by your surgery. Here it's the lung of one of my cases otherwise with bronchopneumonia, which was generated by very aggressive bacteria, which also complicate the bronchopneumonia with a lot of abscess formation in the lung. Obviously dying from septicemia with a lot of such abscesses in his lung. The chronic abscess, here it's another one in a very nice image, have a very thin but present whitish connective tissue capsule, which is a very thin barrier, but at any moment possible to be braked by the pus inside, generating a fistulization. And it's possible for the fistulization from a pulmonary abscess, we take a particular example here, to be drained in the pleural cavity and generating an empyema here, It is possible to for the fistulization to enter in a bronchial tract and to be eliminated in the bronchial tract, infecting in this way other segments of the lung and generating a severe bronchopneumonia. Or it's possible for the same fistula to enter in a blood vessel, generating the septicopemia with potential abscesses appearing from a unique, otherwise initially small abscess located in the lung to produce new abscesses in the brain, in the heart, in the kidney, in the liver, so destroying anything and everything in the way of evolution, and becoming from a initially small, non-important abscess in the lung a killer. Here are such small, microscopic otherwise, abscesses in the myocardium. We can see here the microbe colony, which is blue, granular substance, encircled by not very many, but just a few polymorphonuclear cells, still between the not dead yet myocardial cells. So it's initially phlegmonous inflammation, evolving and transforming in evolution by killing these cells in a small abscess. These abscesses has in the cavity, in contact with the wall, connective tissue wall of the chronic abscess, also have a pyogenic membrane, it's called, fibrinosolid material adherent to the wall, in which this fibrin material, the microbes are living. And being solid, it's not possible to be drained by puncture of the puncture of the old abscess. So draining only an abscess, it's not enough. You need to remove it with the capsule itself to be sure that you remove the entire. For the recent abscesses, just newly formed, still with symptomatology, this only draining is okay because this pyogenic membrane is not yet formed there. And here are such fistulas coming from deep to the surface or entering in any cavity of the body eventually. As a complication, as we discussed already, we can have entrance of bacteria in the circulation, but without capacity for them to proliferate here. This situation, which is quite frequent, appearing very easily, is called bacteremia. Bacteremia, it's a very short situation in which bacteria will be in the blood but not proliferating here and destroyed by the reticulohistiocytal system of our body in just few minutes. And it's happening quite frequently even after you are washing your teeth and having a gingival hemorrhage. Bacteria, otherwise commensal bacteria of the oral cavity, will enter for a short period of time in circulation, generating such a bacterium, but will disappear in just few minutes after that with no consequence at all. When bacteria is entering in the blood and proliferate here, we call this situation septicemia. And when we have septicemia with formation of new abscesses at distance from the initial abscess, is called septicopemia. So these are the terminologies involving the dissemination of bacteria in the. And now a more severe situation of hemorrhagic inflammation, meaning more severe because even more the capillary are dilated and the gaps between are so large that even red blood cells can extravagate outside, giving to the inflammation and hemorrhagic aspect. Obviously making necessary for such a hemorrhagic exudation or inflammation to be differentiated from a hemorrhage. The difference is easy. The hemorrhagic exudate, so the hemorrhagic inflammation, the blood inside it's not coagulating. But in a hemorrhage, not inflammatory, but accidental hemorrhage, the blood is coagulating. So just by presence of clots, you can have a differential diagnosis between a hemorrhage or a hemorrhagic inflammation. Looking like that in the cavities with the blood-like looking liquid, but without clots inside. So we have here a pleuritis, a hemorrhagic pleuritis, a bilateral hemorrhagic pleuritis. It's possible to be pericarditis, it's possible to be meningitis. Here we see such a hemorrhagic meningitis produced otherwise by, it was in the atlas from which I take the image, by anthrax. Usually, these inflammations are extremely severe, produced by extremely severe etiologies like Streptococcus hemolyticus, Meningococcus anthrax, or other such very aggressive bacteria, or even very aggressive viruses. Or Aspergillus, it's a particular mycotic inflammation. We'll discuss about mycosis later in this chapter, which has in immunosuppressed patient the capacity to invade vessels and to generate hemorrhagic inflammation. By the way, I saw such a thing, an invasive aspergillosis with septicemia with aspergillus in a patient died with COVID. The aspergillus entering in the vessels from the lung, so inside the lung. What is remarkable is the fact that this virus, the COVID generating virus, is in some individuals able to generate so severe immunodepression that is comparable only with HIV. So it's extremely rapidly doing it. HIV was not able to do it so rapidly. But it's possible to have such hemorrhagic, very severe, otherwise, as I said, inflammation generated by otherwise not so aggressive etiologies, but acting in the context of previous disorders of the blood, like coagulation disorders resulting from, for example, leukemias. It is a particular exception to the general rule of hemorrhagic inflammation being very severe, and this exception is the hemorrhagic cystitis of the urinary bladder. This type of cystitic, the hemorrhagic one, it's extremely frequent, and is produced by otherwise ordinary non-aggressive microbes or ordinary urinary tract infections of ordinary etiology. So it's for this occasion particularly the presence of hemorrhagic mucosa of the urinary bladder is not necessarily associated with a very aggressive etiology, but in other locations it is, like here in a fibrinohemorrhagic pleuritis, pericarditis, for example, very, very severe, significant hemorrhagic. And now to see the last component of inflammation, meaning proliferation. This proliferation means accumulation at the site of an inflammation of a lot of cells, some of them being coming from the blood, some of them being local proliferating cells. It's usually defining such a proliferative inflammation a chronic inflammation and not in acute ones. These cells accumulating at the site of such a chronic inflammation, as I said, are some of them coming from the blood. And we already saw that polymorphonuclear cells are able to exudate quite easily, but not only them. Monocytes, also circulating monocytes, are in fact the macrophages of the blood. And once they exudate, they are going out in the tissue, they became macrophages of the tissue itself. And these macrophages are necessary to phagocytate more efficiently larger particles than microbes. Larger microbes eventually, or other etiologies which are not microbial. So these macrophages are with higher capacity of phagocytation than polymorphonuclear cells, which are only able to phagocytate small bacterial cells. These macrophages are large cells once they exudate from the blood, coming from monocytes but becoming larger with abundant cytoplasma with an elongated nuclei inside, and proliferating locally. So once they are out, they also start to proliferate. And by this proliferation, these otherwise large cells became accumulating in large number, and they are described as being epithelioid cells, meaning looking like an epithelial cells. This accumulation of large elongated cells. Some of them are even able, of this already large epithelioid cell, to fuse between them and to produce in this way very giant multinucleated cells. These giant multinucleated cells being extremely large macrophages with the maximum possible in our body phagocytic capacity, being able to phagocytate very large particles like foreign body, for example, but also very large microbes, as we'll see, like the Mycobacterium microbes, which are extremely large ones. Also in this proliferating inflammation from blood locally, we can have accumulation of lymphocytes, B lymphocytes, which by accumulation will evolve, transforming in plasmocytes, and which locally will start to produce antibodies, obviously against the etiology of the inflammation. And in this way, adding to the inflammation, the non-specific inflammation, the specific reaction of the body called the immune reaction. So by this exudation, we add a new layer of defense. And also T lymphocytes, which also evolve once exudated in activated T lymphocytes, able to produce cytotoxic substances to kill the etiology or the infected cells. Also, we can have a local proliferation of the previously present there cells by stimulating this proliferation with cytokines liberated in the inflammatory process. Obviously, this will be possible, this local proliferation, only for tissues which are still able to proliferate, not for stable cells like the neuronal cells. They are not proliferating even in such a context. But other, like epithelial cells, they are producing by this proliferation pseudo-tumoral mass, meaning became like a tumor, not being tumor, just proliferations inflammatory proliferation, but looking like a tumor. And we will discuss about some of these pseudo-tumors when we'll describe the tumors themselves. They are not real tumors, but looking like one. Here is such a proliferative inflammation called acuminate condylomas, resulting from the interface between skin and squamous mucosa of the anus or genital tract, infection with human papilloma virus. The same human papilloma virus, when it's infecting the skin itself, it's producing the warts, or the verruca vulgaris, which is also a proliferative inflammation, but smaller than this particularly giant acuminate condylomas. At microscopic level, this proliferation consists in infiltration in the deep of the epithelia, which is proliferating with infiltration of the deep, simulating a lot the infiltrative process of a malignant tumor. For this reason, but it's not a tumor at all, and it's not even possible to evolve in a tumor such a thing. But this particular image is called pseudocarcinomatous hyperplasia of the skin. This pseudocarcinomatous meaning looking like a cancer, but not being one. So be aware, if you will heard in the future this terminology, not to be scared about. It's just an inflammation. We can have such predominantly proliferative inflammations being diffuse, affecting entire organs, like in chronic hepatitis, for example, or to be localized when we have localized proliferation called granulomas or granulomatous inflammations. There are a lot of them with different etiologies. And a lot of types, patterns of granuloma to be formed. And obviously microscopically, because macroscopically granuloma, it's a nodule, smaller or larger. Microscopical sometimes, but it's a nodule. These patterns, different patterns for a granuloma that we are describing here are microscopic patterns. The most frequent and somehow typical granuloma is what is called tuberculoid granuloma. Obviously, it's called like that because it is the microscopy for tuberculosis, but not only. Not tuberculosis granuloma, is tuberculoid granuloma, meaning a granuloma like in tuberculosis. This is the meaning of the terminology. And it's possible to look in the same way in other diseases, like in syphilis, sarcoidosis, berylliosis, cat scratch disease, and so. Even in other non-infectious diseases like Crohn, like granulomatous orchitis, prostatitis, and even granulomatous thyroiditis, all of them with unknown etiologies. So they are pseudotumoral nodules, small at the beginning, but with possible growing in size until even centimeters in diameter, and are microscopically described to have a central area of necrosis. I will make a drawing here. So they have a core, a central core, which is necrotic, meaning amorphous eosinophilic area. This necrotic area, which is initially extremely small and is growing in time by adding new and new cells which are killed by the etiology, and it's adding to the necrotic area in the center. But at the periphery, we'll have an accumulation of elongated macrophages called epithelioid cells. And between them, some of them being fused will have the appearance of giant multinucleated cells. here in this layer surrounding the necrosis of epithelioid and giant cells. These giant cells are with multiple nuclei, sometimes tens or even hundreds of them. When they are located at the periphery of the cells, they are called Langhans type giant cells. When they are in a different type of granuloma, we'll see, when they are large with multiple nuclei but located mostly inside, not at the periphery, they are called giant foreign body type giant cells. So they have different name, but in fact they are the same thing, the result of fusion between epithelioid cells, which are at their time also macrophages, enlarged macrophages. And obviously they are here to phagocytate the etiology, which is inside the necrosis. And at the periphery, even more peripheral, so we have a three-layer structure, the tuberculoid granule, with central necrosis, epithelioid layer, and the third one, it's a crown, a peripheral crown made by lymphocytes, a lot of lymphocytes. The result being a nodule in this way. Here is such an image with necrotic small area in the center, with these epithelioid elongated cells here, including with a lot of giant multinucleated cells, possible easily to be seen, and at periphery a lot of lymphocytes. So this is the typical tuberculoid granuloma appearing in tuberculosis, but also in other conditions. Here another such an image with a much larger necrotic center, with these elongated cells here, the epithelioid one, with giant multinucleated cells between them, and at the periphery the presence of lymphocytes. In this situation, and we'll comment later, probably in the next lecture, why the quantity of lymphocytes here it's not so big as expected to be. Here again, the giant multinucleate Langhans type with nuclei located at the periphery. Here too, and the lymphocytes nearby. Here another such an image with small central area of necrosis, the epithelioid cells surrounding this elongated one, with a very obvious giant cells and very few lymphocytes, but present lymphocytes at the periphery. Very few will understand why later when we discuss about tuberculosis. This tuberculoid granuloma, it's a very typical, frequent one. Also frequent, it's this foreign body granuloma. And as the name is saying, it's formed each time when we have foreign body present inside our tissues. In the try to dissolve this foreign body and to eliminate it, granulomatous inflammation is formed with accumulation at the site of a lot of giant multinucleated cells in the try to phagocytate this foreign body, which can be a lot of things, sometimes from outside entering, like parasites, coal, silica particle, calcium particles, any other foreign body materials, including surgical sutures material. Catgut, it was the name for this surgical suture materials in the past, because in the past it was made from the gut of a cat. Now we have such artificially synthetic made materials for this purpose, some of them being designed from beginning to be resorbable, some of them not to be resorbable, depending on what is the purpose for the suture when it's made. Those who are resorbable by this mechanism of macrophagic accumulation at the site with large foreign body giant cells present in large quantity surrounding the material and phagocytating them. So this is how, in fact, they are resorbed. Sometimes even endogenous substances can act as a foreign body, like crystals of cholesterol, urates, or other substances produced in our body, not coming from outside. They are formed almost exclusively by macrophages, like epithelioid cells, and most of them being already fused in foreign body giant cells. As I said, with the nuclei, a lot of them, but located randomly inside the cell. Some quantity of lymphocytes, plasma cells, xanthomatose cells are also macrophages, are also possible at the site. And here is such a suture material, a composite material formed by small particles, and in the surroundings already accumulating these large multinucleated cells. We can see it in this small magnification here, present everywhere and invading in the suture material in the try to phagocytate it. And even in larger magnification, these multinucleated giant cells here, trying to phagocytate the material, and some of them already done the phagocytation, and we can see the material present in such giant multinucleated cells like these ones here. It's a very slow progressing process, but at the end, some material will be resorbed entirely rapidly. Some of them are designed to be resorbed much slowly in time to give time to the tissue to heal. And some of them are designed not to be resorbable because they need to remain to maintain the resistance of the suture tissue. Here it's a vegetal material entered somewhere in a tissue, maybe a thorn of a rose, maybe something else, not important. What it is important is the fact that in the nearby a lot of giant multinucleated cells are already accumulated here in the granuloma, foreign body granuloma, in the try to remove it. If it's not possible to be removed, a capsule, a connective tissue capsule, like in the abscess, will be formed and will isolate in this way the foreign body from the rest of the tissue. Another type of granuloma, also quite frequent encounter, it's what is called pyogenic granuloma. In fact, appearing on the surface of the skin most frequently, but also possible on the surface of the oral cavity. They are, in fact, granulation tissue covered on the surface with a layer of pus. And the presence of pus there, it's not letting the granulation tissue to evolve in a connective tissue scar, so to heal. So the irritation process, it's maintained, and the granulation tissue, it's lasting for a long period of time, covered with some degree of pus on the surface. This is why it's called pyogenic granuloma, because it's producing pus by granulation tissue, which is destroyed continuously by the microbes on the surface, but also regenerated again and again continuously, this granulation. And looking like a hemorrhagic, otherwise painless. It's hemorrhagic on touch, easily hemorrhagic, but not spontaneously, and completely without pain or any sensation at their level, because they are only granulation tissue, so they don't have inside any nervous termination to be sensitive for anything. In the oral cavity being possible also to be formed. And now, just starting a few ideas about the prototype for a granulomatous inflammation, which is the tuberculosis. Well, we are just starting because it's a very important topic, and finishing next time. Probably next time even finishing the chapter of inflammations almost. For the moment, why is so important this particular disease called tuberculosis? It's important because it's frequent. The Mycobacterium tuberculosis, which is the etiology, being present everywhere, in small quantities are present anywhere. And it is present anywhere because it's a very resistant microbe. It's a very big one. And has a capsule on its surface which make it extremely resistant to anything. We cannot kill this bacteria only with a very high temperature, more than 200 degrees Celsius. It's killing the bacteria. Otherwise, the rest of temperatures is not killing. So fever or even higher than fever temperatures are not killing the bacteria. It can survive outside in the moisture or not moisture environment, in cold or very warm climate, but it's not dying. It's very resistant, having this capsule, which make it also very big, this bacteria. And for this reason, as we'll see, to phagocytate it, polymorphonuclear cells are not able to do it at all, so they are needed macrophages for the phagocytation of this bacteria. So they are the cells attracted by the presence of it in our tissues when it is present. Also, this bacteria, which is not killed by any antibiotic, so we don't have a killer for the bacteria, but we have, fortunately, a medication for it. It's called tuberculostatic medication, consisting in just a very few substances, but they fortunately are, which are able not to kill but to block the proliferation of this bacteria. And by blocking, giving the time to the body to resolve the problem of this infection. The proliferation otherwise of the bacteria is extremely slow because of the capsule present there. In fact, one such bacteria have a division each 3 days. Only one division in 3 days. Any other bacteria in 3 days already multiplied in millions of copies, millions or billions even. So they are proliferating, but very, very slowly. For this reason, in fact, when we are infected with this bacteria, we have all the time to react against it. And for this reason, in fact, in most situations, in 99% of the contact between this bacteria and a human body, the human body will win without even knowing that such a thing happened. Just a few, less than 1% of population will develop the disease, and this is possible only in the context of low and long duration low immunity. So not only low immunity, but also this low immunity to be of long duration. Then our reaction against the bacteria is not good enough, and the bacteria slowly but surely will proliferate and will generate evolving and extending disease by extending the infection from the initial site to, if it's possible, the entire body. It's important for you to know that for us working in health system of any specialty, the contact with this bacteria is inevitable. And the probability is higher in a poor country than in a rich country, for the simple reason that in poor countries, because of low income, a lot of people being very poor don't eat enough, don't eat, maybe they eat enough but not good quality food to have a good and resistant immunity. So they are lowered in their immunity for a long period of time because they are for a long period of time poor. And in this context, poor countries are much more aggressed by tuberculosis than others, than the Western countries, for example. This is also the reason why poor countries has a national vaccination program for tuberculosis, and Western countries don't, because they consider that it's not necessary for them having just a very few and isolated cases of tuberculosis, but being present much largely in the population in poor countries, they need such a program of vaccination, who is trying, in fact, nothing else, just trying to increase the immunity for an otherwise poor person, to increase immunity enough to resist to the aggression of the disease. But not always being efficient, this vaccination, unfortunately. Efficiency is somewhere to 70%, but not 100%. And starting from here, we'll continue next time, but maybe even telling you a little bit more about what means to be with low immunity long time to develop the disease. Means not only to be poor, because obviously poor persons and poor populations are unfortunately the main clients for developing this disease. Children's particularly, because even if they are not poor, they have a low long duration immunity, which is not secondary to anything. It's just an immaturity of their immune system during the childhood period. So they are particularly exposed. This is why they are vaccinated, at least in our country and other more poor countries like us. They are vaccinated in the moment when they are liberated from hospital after they are born. So in the day 3 or 4 after life, they are vaccinated, mandatory in our country against tuberculosis, to give them the chance during the childhood period, if they will enter, and the chance exists, if they will enter in contact with the Mycobacterium tuberculosis, not to develop the disease, having the, at least on this side of the immunity, having a resistant enough immunity to fight against. Later bit, when childhood period is finished, the immunity is gained his normal level. You, for example, coming from Western countries here in Romania, you are at risk to be exposed to the Mycobacterium, and probably you are already in contact with it, but without any consequence and any importance at all, this contact, because you are not anymore a child, even if you didn't do the vaccine in your country. So not vaccinated being, but adult being now with a normal, just normal immunity, you are not at risk at all when you are entering in contact with the Mycobacterium tuberculosis. I, for example, perform autopsies for patients dying with tuberculosis in, I don't remember how many hundreds of cases, children and adults. And doing so, obviously I was exposed directly to the contact with the bacteria, but never happens nothing. For me, being an adult, being with a normal immunity, and obviously being a well-nourished guy is one of the reasons for which I am eating well, to maintain a good level of immunity and being protected in this way, not only against tuberculosis, but against a lot of other diseases. I don't know, I was not yet infected with COVID, but I hope that even in COVID situation, my immunity will act very, very efficiently. It is well known that pathologists in general everywhere in the world have a very strong immunity because of their exposure, professional exposure. But are other category of persons which are on risk to develop the disease. For example, those which are affected by autoimmune disorders, they need for treatment to lower their immunity. So they are treated with drugs which are decreasing the level of immunity. And obviously, having an autoimmune disorder, you need to take this treatment for the rest of your life. And in such a condition, they are particularly at risk to develop the tuberculosis disease. Also, any patient which suffered a transplantation with an organ, this transplantation means that to not reject the transplanted organ, you need to lower your immunity with medication, which also will make you a candidate for tuberculosis with very high risk being. And not necessarily to mention anymore, obviously the HIV infected patients are at risk also. And it's very well known that in Central Africa, where the number of HIV positive persons is very high, more than 90% of them are dying not because of HIV itself, but because of tuberculosis on this background. So this is something to know, which of us are at risk to develop the disease called tuberculosis. But most of us, with just being normal, nothing else, eating normal, nothing else, we are not at risk, even if you are professionally in frequent contact with this bacteria. Thank you for your attention, and we'll continue from here next time.